Hello, everyone. Welcome back to our weekly Sunday meeting. This is our 114th consecutive IMA DMA meet. And today we have a special speaker with us, Dr. Surbhi Chhabra, who's the consultant emergency and trauma physician in Yatharth Hospitals. And she's done a fellowship in mental health disease and is also a coach and motivational speaker. So today we are going to be talking about a very pertinent and a very important topic in today's time, and that is mental health in pregnancy. So, without much delay, I would request Dr. Surbhi Chhabra to please come forward and conduct this very important session. Over to you, Dr. Surbhi.
Thank you, Dr. Meenakshi. Hello, everybody. Good morning. I hope your Sunday is going good. So today, the topic which we have decided is going to be the mental health in pregnancy. So I just want to give a little introduction that why this topic has been chosen for today's meeting. So I feel, just a little bit about my story, because when I was pregnant, I think being a doctor, I was aware about the medical aspects of pregnancy. But there were certain things which I was not really sure of, like the emotional balance and the family balance. And the first pregnancy for any lady is really, I think it's a roller coaster ride. So even though I was very much sure of the medical thing, being working in emergency, I was working throughout 9 months. But then, yes, I had to face and go through a lot of challenges. And because of that, I realized that how difficult is it for any other people, any other women who is going through the same thing, to make those decisions and to take care of her emotional health and to take care of her, the family support, and everything is so important. And that's when, after I did my fellowship in mental health diseases, I realized that being a lady, we need to be aware about our health. And pregnancy is a time where a lot of things, a lot of changes, the physiological changes happen in the body. So I feel every lady, every patient which we see, we cater, we should be, informing that lady about this particular phase, which is pregnancy, because pregnancy is really important for any would-be mother. So that's what we're going to be talking about today, which is going to be the mental health in pregnancy. So I hope my screen is visible here.
Yes, everything is visible. It's fine.
So there are certain pointers here. We'll be talking about health. We will be talking about mental health. And why is it so important to cater mental health in pregnancy? We'll be talking about the antepartum depression, postpartum depression, followed by postpartum psychosis, and how can we prevent it? Because of course we can treat it, but then prevention is always better. And as a clinical practitioners, we must know that we should during the pregnancy or during that particular phase, we must assure our patients and the women around us that they take care of their health so that they don't cater all of these emotional and the changes and the depressive or the anxiety phase. Just a second. Dr. Meenakshi, my screen is frozen for some reason.
I can see the pointers here.
Yeah, but
with a diagram of the brain.
It's not. Okay. So about health. So we all know that health is not just the physical health, but it is the physical, mental, and the social well-being. So we have to cater all of these three aspects of health, where our physical, we need to be physically healthy, that our body is free from diseases. We need to be mentally healthy, that our brain is working properly and we are able to cater the situations which we are facing in a day-to-day life in a very positive way. And then social well-being. So socially, that we are adaptive to the relationships, to our family, and to our friends, and professional balance also. So that's how we all know that WHO defines health. So now what exactly is the mental health? So mental health is defined by World Health Organization as a state of well-being in which the individual realizes that his or her own abilities can cope with the normal stresses of life. We all know that being GPs, being clinicians, we have our own stresses in life. And so even even after knowing that what exactly health is all about and being in the medical field, it's, we are also stressed. So how about the layman, how the people who are into the day-to-day life? And then pregnancy again comes up with whole lot of things, whole lot of changes. So when catering to the mental aspect, it should be that the work should be productive, fruitful, and a person is able to make a contribution to his or her community. So that's precisely the mental health definition that has been given by the World Health Organization. And the World Health Organization states that the mental health is more than just the absence of mental disorders and the disabilities. So if a person is able to adjust in his or her own surroundings and able to make those changes and cope up with the normal stresses of life, that is when we say that the person is mentally healthy. And the peak mental health is about not only avoiding the active conditions, but also looking after ongoing the wellness and happiness. So wellness, happiness, contentment, all comes a part of our mental health. Now coming to the next slide. Sorry. Okay, mental health in pregnancy. So why are we catering the mental health, as we have already spoken about, in the general population? Why is it so important that during pregnancy, women are really, it's very important for any lady to take care of her mental health, because we all know that motherhood is the most permanent change that any mother, any lady makes in her life. And it's just as important to look after the mental health and well-being during the pregnancy as the physical health. So if lady is mentally healthy, obviously she'll be fine and she'll be able to cater the challenges which she's going through in the pregnancy. So we all know that women, for most of the women, pregnancy is a happy phase, but then that can be overwhelming too. And that's why, there are the mixed emotions, and because of which the woman is not able to understand that, oh, she should be, usually people say that the woman, if she's conceived, there's a lot of family thing happening, and usually people say that the women should be happy. But these days, there are a lot of women who get pregnant because of and they don't really feel happy, but they have like mixed bag of emotions because of a lot of factors that we will be discussing about. Okay, so many things are there that can affect a pregnancy, which are like the physical symptoms, which include morning sickness, and the support, the family support, if she has or she doesn't have that support. Women often worry about that, how she's going to cope up with the pregnancy and the baby. So that can make her anxious. And the changes in the role, becoming a mother, taking care of the work-life balance that she already has in her mind, that what about her work? What about her job? Changes in the relationships. Again, the pregnancy comes up with a lot of challenges, and one include the relationship too. And then the women have this thing that if she'll be able to be a good parent or not. And there are the fears that there might be some problems with the baby. What if the baby is not healthy when the baby is born? And then again, the physical problems, the pregnancy complications. And then a lot of women who are afraid of childbirth, who are afraid to give birth, who are afraid of labor. So there's even a term for that, that's called tocophobia, which is called the fear of undergoing a labor. So that's again, and almost out of, if we see it statistically, out of 10 women, 3 women are the ones who suffer from tocophobia, that they are really scared of the labor process and giving birth. And then again, the lack of support. If there is a lack of support, or if it's an unplanned pregnancy, then all these problems are even more. Now coming to the antepartum depression. So as I've already discussed, that pregnancy is a real exciting time, but then it comes with a lot of stress and anxiety, which can actually worsen the depression. So this particular depression is called antepartum depression, which happens during the pregnancy. So as per the research, 7% of the pregnant women suffer from antepartum depression. And this percentage can go as high as 15% in a few countries. So the countries like UK and US, the 15% women suffer from antepartum depression. The point is that how to diagnose it, because a lot of symptoms of antepartum depression and anxiety, they get masked with the normal symptoms of pregnancy. So it's really important that we take a thorough history of the patient, of the pregnant women who's coming to us. And if we're suspecting anything which we think that might, lead to antepartum depression, or even there are any red flags or signs that we think the lady is going through antepartum depression, we have to investigate her right there and then. And it is also sometimes known as the maternal depression, prenatal depression, or the perinatal depression. So all of these are the synonyms to the antepartum depressions. Now coming to the signs and symptoms. So what are the signs of symptoms which we can actually see? The other warning signs of the red flags. So there'll be lower energy levels, there'll be fatigue, changes in appetite, changes in sleep, changes in libido, very anxious, feeling very anxious all the time, having low self-esteem, feeling dreadful, feeling that you're not prepared. The women tend to lose interest in the activities which they really used to enjoy before. They feel unmotivated to take care of themselves. They feel unmotivated to follow a pregnancy health plan. They're not able to eat properly. They do not gain enough weight. Either they sleep less or they sleep too much, or then they also start smoking and drinking even after knowing that it is not okay for them and for their baby. So as we see that all of these symptoms, like most of them, they are the symptoms of pregnancy, including the lower energy levels, fatigue, changes in appetite, and all of this. So that's precisely the reason we have to really investigate, which is done by thorough history and thorough examination as well. So again, coming to investigation, we need to look for the causes and the risk factors. So precisely the cause is idiopathic. We really don't know what exactly is triggering the antepartum depression, apart from the history, of course. But the other causes are the lack of social support, history of depression. If somebody has already undergoing depression before the pregnancy, so chances are more that the lady is going to end up into the antepartum depression. If that particular lady has mood disorder or anxiety in the past, if there are history of sleep disturbances. Also, there are studies which show if there is a deficiency of vitamins like vitamin D, vitamin B, and zinc, that has also led to the depression in pregnancy, including the antepartum and the postpartum depression. So there have been a lot of research which has been conducted, and that is why these days, not just iron and calcium, but vitamin B complex and vitamin D and zinc, they're also added into the nutritious requirement for a pregnant lady. And again, the causes are unintended pregnancy, when the lady is not really prepared and the pregnancy comes as a surprise to her. So in that case, again, the chances of antepartum depression are really high. History of smoking, if the lady has been smoking, so it also causes imbalance and hence leading to the antepartum depression. And of course, the lack of pregnancy education. So it's really important for any pregnant woman to know that what exactly she's going to, cater through her pregnancy, what kind of moods or what kind of physiological changes she would get to have. So this way she becomes prepared, and the chances of anti and the postpartum depression reduces significantly. Coming to the effects of antepartum depression on pregnancy. So antepartum depression affects more on the mental and the emotional health, and also can affect the physical health of the female, and the physical health and the health of the baby also. Because if she's not eating well, if she's not taking care of her multivitamins, of her routine, of her diet, of her exercise, that is going to directly or indirectly affect the baby in the uterus. So also the studies have found out that the antepartum depression has the clear-cut related to the complications like preeclampsia, low birth weight babies, earlier the preterm delivery, C-section delivery, and followed by the postpartum depression and even the psychosis. So again, the point here is that if we are providing the proper education and if we are providing the proper counseling to the pregnant women, what we are doing, we are taking care of the baby, of course, and we are taking care of the women's mental well-being and preventing her from a lot of complications during the pregnancy and even in the postpartum period. So the screening and the diagnosis is, the thorough history is really important. And apart from that, the screening and diagnosis, the American College of Obs and Gynecologists recommends the doctors and the healthcare providers screen all the women for antepartum depression at least once during the pregnancy. So it's really important that during the 9 months, at least once the screening should be done. If she's cleared for once, then we can really be like, after the history and the evidence and all, that okay, the chances are really low. But if we see any red flags, then we have to screen her on a regular basis after every trimester. So the standard questionnaire is scored, and that is used to diagnose the antepartum depression. So that questionnaire we'll be discussing. So the treatment of antepartum depression is counseling, therapy alone, therapy with antidepressant medications. Lifestyle modifications go a long way in improving the antepartum depression. Exercise, nutritious, and also the certain antidepressant medications like SSRIs, selective serotonin receptor inhibitors like citalopram and sertraline, they are absolutely safe if given in a proper dosage. And SNRIs are also the choice of treatment for the antepartum depression. Coming to the postpartum. So postpartum is a complex mix of physical, emotional, and the behavioral changes which happens in some women after giving the birth. So if I talk about the Diagnostic and Statistical Manual of Mental Health Diseases, that is DSM-5, this is the manual which is used to diagnose the mental disorders like postpartum depression, which begins within the 4 weeks of delivery. So it's really important that we screen every pregnant lady who has delivered to look for if there are any signs for postpartum depression. The diagnosis of postpartum depression is based only on the length of time between delivery and the onset of the severity of that depression. And if we talk about statistically, about 1 out of every 10 of these women will develop more severe and long-lasting depression after delivery if the lady already has features of the signs of antepartum depression. And statistically speaking, 1 in 1,000 women develop a more serious condition known as the postpartum psychosis. Coming to postpartum depression, the chemical changes, it involve a drop in hormones after delivery. We all know that estrogen and progesterone are really high in the delivery because that's responsible for the baby's growth. But after the delivery, these hormones go back to almost their normal range. So that's link between the drop and the depression. It's not really clear as per the researchers, but then yes, because they have been increased tenfold during the pregnancy, and then there's a sharply decline, and that is why it actually leads to the postpartum depression. Apart from that, there are a lot of chemical changes like social and psychological changes, which are the reasons for the depression. So signs and symptoms, if we talk about, are the depressed mood or the severe mood swings, excessive crying, difficult bonding with the baby, withdrawing from the family and friends. There's a loss of appetite and eating much more than usual, insomnia or sleeping too much, overwhelming fatigue or the loss of energy, reduced interest in the pleasure in the activities that were enjoyable before, intense irritability and anger, fear that you're not a good mother, hopelessness, feeling of worthlessness, guilt, shame, diminished ability to think clearly, concentration or make decisions, restlessness. So there are all other signs and symptoms which we have to look for in a patient, in a woman who has just delivered, and we're screening her for the postpartum depression. So the causes, as we already discussed, they're the hormones, because there is a sharp decline in estrogen and progesterone level. Then depression during the pregnancy. If there has been an antepartum depression, then we have to screen the lady for postpartum depression. Anxiety during the pregnancy. So if there is a stressful life event that has happened during the pregnancy or early postpartum period, that can also contribute to the postpartum depression. Traumatic birth experiences, as I've already discussed about the tocophobia, because a lot of women have this fear of labor and childbirth, and it's really important to provide women with the labor support and the labor educational classes so that they know that what to expect in the delivery room, in the labor room, or even if they are going for a cesarean section. So because again, if we are providing that education to the women, we are contributing majorly to prevent the postpartum depression. Also, the causes can be the preterm or the infant admission to the ICU or the NICU, low level of social support, and the history of the depressive disorder. So these are all the causes of postpartum depression. So this is the Edinburgh postnatal depression scale, and that's how we screen the pregnant female. So it's a questionnaire which is provided. The questions are to be asked to the female, so that the questions are like, example, like, I have felt happy. Number 1 point is yes all the time. Number 2 is yes most of the time. Number 3 is no, not very often. Number 4 is no, not at all. So these questions are to be asked. This questionnaire has to be provided to the pregnant lady who has just delivered, like during her postpartum period, preferably after 2 to 3 days after she has delivered. And as per this, we have to find out that if she is into the category of postpartum. So the scoring is done that, so maximum score is 30, and the possible depression can be there if the score is 10 or plus. And we always have to look for, like, if there are any suicidal tendencies or anything in that has been there in the past or during the pregnancy or after delivering the baby. So this scale, the EPDA scale, Edinburgh postnatal depression scale, is one of the diagnostic marker which we use after the lady has delivered. So coming to the treatment of the postpartum depression. So sometimes postpartum depression goes on its own after 3 months of giving birth. But if it's interfering with the everyday life at any time, or the other blues, it can last longer than 2 weeks also. And so if that's happening, one should always seek the treatment. So the treatment can be the lifestyle modification, balanced diet, avoiding alcohol and caffeine, yoga, meditation, holistic lifestyle. Then foster the relationship with the partner, family support, social support is very important. Sleeping is really important, because sleep is because a pregnant lady, after she has delivered, there is like lack of sleep, that is also contributing to the postpartum depression. Breastfeeding. There have been a lot of researchers which say that the women who breastfeed their children exclusively for 6 months, they tend to get less chances of anxiety or the postpartum depression. And the screen time needs to be reduced. Even the screen time is related to the postpartum depression, the high screen time. So the treatment would be the combination of the medicines, like, they can be the medicated therapy, as we've already discussed, SSRIs, and the other things are the psychotherapy, like cognitive behavioral therapy, which involves the counselor and the patient works together to identify, they change the habit, the pattern of thoughts, and then the behaviors that are harmful for the mental health. So there is a proper relationship between the counselor and the patient, and that's how they work over a period of 2 to 3 months. And then there is the interpersonal therapy, when therapist helps and makes the patient understand how to behave in various relationships. So that's how the postpartum depression is to be treated. Coming to the postpartum psychosis, as we have discussed, that 1 in 1,000 women have the chances to land up into the postpartum psychosis. So it's a very rare condition and typically develops within the first week after the delivery. The signs and symptoms are severe, but they include confusion, disorientation. There can be obsessive thoughts about the baby, hallucination, delusions can be there, sleep disturbances, agitation, paranoia, and the attempts to self-harm or the suicidal tendency. So if we are finding any of such symptoms, then we have to look for the postpartum psychosis. So the prevention again is that counseling should be done throughout the pregnancy, after the woman has delivered, during the postpartum period. Then again, the CBT or the cognitive behavioral therapy is the treatment where counselor and the patient is working together and indulging into the positive activities like social interactions and the pleasant events. And then there is the interpersonal therapy, where the interpersonal conflicts are resolved. Again, the counselor and the patient, they navigate together, and that's how the transition is made from the pregnant lady to the postpartum and to the mother. So now coming to the role of a pregnancy coach, the role of pregnancy coach is really important. I've been doing the pregnancy and the postpartum counseling since last almost 3 years now. So it's really important. What I do as a pregnancy coach, I empower them throughout their pregnancy, so that they are better prepared how to actually cater during their pregnancy, what to exactly expect in the labor room, how can they be prepared, what exercises are they supposed to do during the pregnancy and the postpartum period. So that's how, by providing them the right information about their physical health, their emotional health, their mental health, and of course their relationships, it's really important. And that's how we can prevent the antepartum, postpartum depression, anxiety, and the psychosis also. So yes, so that was all about it. I'm open to the questions now.
Thank you so much, Dr. Chabra, for this wonderful presentation. It's a very important topic, albeit it's much less talked, I think, in India. Although I think that, most of the people that we know, they are struggling with some sort of mental health issues, and there's a lot of I think stigma associated with mental health issues in our country, and no one really wants to talk about it. But probably the more we as doctors talk about it, the more the patients are going to be a little more receptive to it, and they'll accept these problems a little more. So thank you so much. It's a very important, I believe it's a very important topic to discuss in these times, and especially I think after COVID, these things have just crept in a little more, because a lot of staying indoors, and a lot of losses that people have suffered. So these things have just been sort of surfacing a little more. The floor is now open for questions and any discussions that anyone might like to do. So if there are any questions, we can take them now. Nothing in the chat box. You can either write in the chat box, or we can talk about it maybe.
Madam,
yes, please.
If the patient has a pre-eclampsia and with depression, what is the therapy? Do you terminate the pregnancy, or will you continue the pregnancy?
So let me just repeat your question. So you're asking if the patient has pre-eclampsia and the patient has depression also. That's what you're asking?
Yes.
Okay. So we would not really terminate the pregnancy. We have treatment for pre-eclampsia, and so we'll have to counsel the patient. And for pre-eclampsia, we'll put the patient on the BP checkups, and on the BP medications and everything. We'll be doing a lot of investigations in terms of pre-eclampsia, and BP monitoring will be there. The lifestyle modification will be there. We may, if the depression is really high and we are looking that, okay, the patient needs medical treatment and it's not being relieved with just counseling or the lifestyle modification, we have to use SSRIs. I've already discussed the SSRIs are really safe in pregnancy. So we'll put on SSRIs also. We'll take a psychiatric consultation. We would not really terminate the pregnancy, but yes, the close monitoring is required. The psychiatric and the psychologist support is really required. And then we will see and we will cater the complications. So termination would not be the choice, but yes, the patient might land up into the cesarean section. That can be there.
Can we use the SRI during the first trimester of pregnancy?
Yes. But then it's again the risk and benefit ratio has to be taken care of. But then, yes, if required, we can use it in the first trimester also.
And how long it can be continued during the pregnancy?
So initially, if we are seeking that the red flags are there in the patient has antepartum depression, and we have all those signs and symptoms that are there, and just the counseling and the modifications are not helping, then the entire pregnancy, the patient, the pregnant lady would be there on SSRIs, and even during the postpartum period, because we know that the causes of postpartum depression are really high in a pregnant lady who has antepartum depression. So we will be using SSRIs for at least after, the child is delivered, for at least 3 to 6 months also. So that will go on for a considerable period of time, and then gradually will be tapered off. We can't really stop them at once.
Madam, many times we see the comorbidity of the patient like hypothyroidism and gestational diabetes. So what is the line of treatment you will continue?
Okay. So gestational diabetes, I think that's really common. And in pregnancy, it depends if we have to put the patient on oral hypoglycemic drugs. Sometimes the oral hypoglycemic drugs are not tolerated. So we also need to put the patient on insulin. So that's been there. And hypothyroid, we don't do anything. If the patient already has hypothyroid before pregnancy, then she has to continue the medication. But yes, we need to look for the baby monitoring and everything on a regular basis. Level 2 scans and other scanning and the ultrasound has been done. So that would be there. The medications will continue.
what about the diet during the pregnancy? Which type of diet will you prefer?
Okay, so the diet, if the patient has hypothyroid and diabetes and even the hypertension, then again the salt and the sugar restrictions will be there. So I always advise, the pregnant ladies I cater, that they have to take everything in moderation, the sugar and the salt, because we already know that the salt intake again can lead to the BP and the eclampsia and pre-eclampsia phase. So the natural diet is always good. Home cooked food is always good. So avoiding junk goes a long way in preventing a lot of complication and seeking the best health for the mother and the baby. So that's all about it. Like natural products all the way. Like if the patient is taking, if the lady is taking like normal home cooked food in a moderation, even if she's consuming sugar, but in moderation, that would be okay.
I have a point for hypothyroidism with pregnancy. We have to
Yes,
maintain TSH at 2.5.
Yes, ma'am.
It should not be
Absolutely.
more than that throughout pregnancy, and it has to be monitored well.
Absolutely, ma'am. Yes, ma'am.
Dr. Surbhi, thanks for a wonderful lecture. Starting and there are indications for starting antidepressants during pregnancy and in the postpartum period. When do we stop? It's stopping the medication.
Sorry, sir, I didn't get your question. When do we stop the antidepressants?
When do we stop after once we have started the antidepressants?
Yes, sir. So, sir, the stopping of the antidepressant never happens like all at once. We will have to monitor and taper it. Like we'll taper the dose initially, and that would be done in consultation with the psychiatrist. So the entire role, what we do is, if we think that patient has to be put on antidepressant, so the role would be of psychiatrist. We always involve psychiatrists in that case. And then if during antepartum, suppose we have started SSRIs as per the dosage in the standard dosage, that would go after postpartum also for at least for 3 months, followed by the tapering of the dose. And that is going to be there in accordance with the psychiatrist only. So we can't really stop it all at once. So the cognitive behavioral therapy and everything would go hand in hand, even the counseling part.
Pregnancy is a stress state, and many diseases get manifested during pregnancy, like depression is one of them. Now, once suppose you've started a therapy, stopped it at some stage, what are the chances of these patients developing depression in later stages of their life?
So chances, mostly what we have seen, like I have catered a few patients, like I've counseled them as a coach who have landed up into postpartum depression. So mostly what I have seen in like, if I talk about like in person, so either they have like IVF that has been happening. So they have been struggling to get pregnant, and there already has been history of a lot of stress, anxiety because of the IVF injections and the failure of IVF rates. And plus the age is high. A lot of people, a lot of ladies who are getting pregnant by IVF at 40 years, and then they deliver. And plus IVF may mostly we have seen that there'll be twin pregnancy and then there'll be complications. In that case, yes, the postpartum depression gets manifested really high. And that's when we really, want to cater those patients, counsel their patient after the pregnancy for a considerable period of time. But then if the lifestyle modifications are there, if the patient is, like taking care of herself and knows things, so the chances usually decrease after pregnancy. But then it's a very relative thing because the stress, anxiety and all that, so yes, I can say that it depends from person to person. But yes, if the pregnancy there are like the patient is on antidepressant and there is a history of anxiety and depression, so that might go on for a longer period of time.
Relative incidence of depression in spontaneous pregnancies and IVF assisted pregnancies. I mean, how much is the difference between these two groups of patients?
So usually what I have seen in my practice that IVF patients tend to have more anxiety and antepartum depression as in comparison to the spontaneous pregnancy. If the pregnancy is planned, the chances are really low. But if it's a surprise or if it's like unplanned pregnancy, or if the mother is catering the professional and all those pregnant and the work-life balance, then the chances also increases. So these days, even very young women are getting into antepartum depression and postpartum depression because they feel that they have to leave their job and they can't manage it, and the lack of social support and nuclear families. So again, that's very strong contributor for like the depression and anxiety during pregnancy.
And
Madam, if the patient has a postpartum psychosis, then what is the health treatment of the baby?
So yes, the baby, in all these cases, the baby tend to suffer because obviously if the mother is having the depressive thoughts and then landing up into psychosis, first of all, the baby's breastfeeding is going to get suffered. So there has to be someone where we need a lot of social support in such cases. Maybe the father or the family has to come forward because the mother is already struggling. She feels like more guilty that she is not able to provide the nutrition to the baby and take care of the baby. In that particular case, that's what we do in terms of the CBT, which we are providing to the cognitive behavioral therapy, which we are providing to the mother. We need to counsel the family as well in that case. So, because that would be good for the baby. So that is what we usually do. We do cater the family all together, like, at least the father and whoever is who are the people who are staying in the same house. So that's really important.
I have a point that in early pregnancy, first trimester, we should not unnecessarily start with SSRIs because we don't give any medicine in first trimester. Try to do counseling. And just from doctor's mouth that you remain happy is a very big sentence. Remain happy. This is what we have to tell the patient. And SSRIs or any medicine we avoid. Even paracetamol we had, unless there is pathological depression or real psychosis.
Yes, ma'am. Absolutely, ma'am. First line is always the counseling, and then comes the medical part. But after, if following the particular scale, then if we really think the patient need SSRIs, then we have to choose for, as I already told, that the risk benefit ratio would always be there, and that's how we will start SSRIs, and in accordance with the psychiatrist and the gynae obstetrician.
Madam, during pregnancy, many ladies have the mild to moderate anemia. Then what is the oral therapy should be given or parenteral therapy should be given?
So in anemia, we usually start with the oral doses. We really don't want people to go through the parenteral or IV administration. We would put the patient on oral iron and folic acid supplements, and we would encourage them to have the dietary supplements which are rich in iron. And we always tell them that if you are nauseatic, even if you're vomiting because you're taking iron and folic acid supplements, that may cause nausea in certain females. So we it's okay, just have your food, and even if you're vomiting, it's fine, it's okay. So we have to really counsel them even with the medications. So if I talk about, maybe not medicine, but in general aspects, so I always tell my my clients and my patients that always pray, always charge your medications, because that helps. If you're taking your medication with the thought that this is helping me and my baby, so that will help you, even in the absorption. So, but yes, if we feel that hemoglobin is really low and even after oral administration, it's not rising, then we would definitely go for IV administration. So it depends on how well it is tolerated by the patient, by the pregnant lady.
Right. So there's a question in the chat box, how to prevent postpartum depression with measures taken during antenatal care. So prevention of postpartum depression.
So prevention of the postpartum depression would again be the proper counseling and proper empowering the pregnant female. Like initially we have to educate all the females that what are the changes they're going to go through. So whenever they're going for an antenatal visit, we have to tell them that, okay, you might feel nauseous, you might vomit, you might not be able to digest, not even your medication, and which is all absolutely fine. Till you are able to digest oral food, till you're able to take orally, it is absolutely fine. So the counseling helps. And the other things, the social support, the family support comes a big way in prevention of the postpartum depression. And the other things, the nutrition, we have to provide nutrition. We have to provide nutrition in terms of diet, lifestyle modifications, and if required, supplementations like vitamin D, B, zinc. So all of these things are to be taken care of during pregnancy.
Right. So I also feel, Dr. Chabra, that, sometimes asking the, so and it's an old adage, and idle mind is a devil's workshop. So asking the, so earlier the women would knit or something, basically looking forward to a positive experience, and they would be knitting for the baby, or basically they're occupying their mind and body in some sort of creative sort of spending their time with some sort of creativity. And I really believe that that helped a great deal with sort of managing your feelings and your emotions, because when you're doing something creative, I think for women it really helps. So do you find that there are hobbies or something that they should take up? Another question I wanted to ask is that, have you ever, like, what is the age group that is more susceptible to depression? Would it be the younger girls, or would it be like, these days we have all these, young mothers who are conceiving at the age of 35, 40 as well. So which age group do you think is more susceptible, and should we as physicians look out for these kind of problems?
Okay, so I'll cater the first question first. Like you mentioned it beautifully. Earlier our mothers, our grandmothers used to knit. The scientific reason for that was, it is believed that why do we say that mother should be happy, mother should be talking to the baby in the womb? So it goes a scientific way. What we are looking for, the neuronal synapses. We are looking for the neuronal connections. The brain development starts as early as the 4th week. 3rd to 4th week, and somehow in most of the cases a lady doesn't even know that she's pregnant, but the brain has started forming. The brain of the baby is forming inside the womb. So by doing knitting and by engaging in all these things, what we are doing is we are generating the synapses between the neurons inside the baby. So it's like the left brain and the right brain development has started in the baby. So what we're doing, we are putting the left and the right brain development in a way that the intellectual part, the creative side. So that's why we always say that whatever you eat or whatever you drink or whatever you think, that's how you are contributing to your baby during the pregnancy. So again, the scientific evidence goes to a way that you solve a lot of puzzles, you do a lot of mathematic things, or maybe some creative things, knitting or anything. So again, you're contributing to the brain of the baby. That's how the brain is getting stimulated, because you are linked to your baby, right? And that's
you're also occupied in doing that. So you, as I said, the idle mind is the devil's workshop. So if you are occupied and putting your brain to good use, it always helps, I feel. So I think that that image of a mother, expecting mother sitting and knitting or doing any sort of creative work, and you are also basically making it for the baby. So you're putting in all the positive thoughts and not thinking about what might go wrong, but thinking about what is to come. So, that's something that I've always related with pregnancy and depression. Yeah.
So coming to the second question, the age group. So I feel still the chances are high as the age progresses, because the complications are high in that case. The Down syndrome, we see a lot of cases of Down syndrome these days. Even the preeclampsia goes really high. And then the IVF treatment. So the chances are mostly high after 35. That's what we have seen, because a lot of complications tend to manifest with the age. But then again, I would say it's relative, because I have seen a lot of young women who lack social support and who lack the understanding. They are also falling into the category of antepartum and the postpartum depression. But statistically speaking, it increases with the age.
Right. So, probably when we see the elder, and you also, I think, mentioned that, the IVF patients, somehow they are reporting more of this. So I think as the age progresses, even the chances of the patients going through IVF would increase. So I think that would also contribute to those numbers. So a great and beautiful session today, Dr. Chabra. Thank you so much for doing this with us. And a big thank you to all of you for joining in and asking all the questions and making this session really fruitful. Thank you again, Dr. Chabra, for priming us on this very, very important topic. It was great having you, and we look forward to more sessions with you in the future. Although I just wanted to make a small announcement that we are temporarily stopping this session for the coming weeks. We would be restarting it again soon. We'll just have more information for you, and we'll be sort of posting it on the groups and on Facebook and YouTube. All our other sessions are still going on. So whoever, all the doctors who are interested interested in taking sessions with us, please do contact us. I think you all have my number, and HCFI is very, very easy to contact. So you can just put in message, and we'll be happy to hear from you, and happy to take you on the sessions. Thank you very much. We'll see you again.